My name is Jerry Mitchell, and I'm a founder and investigative reporter for the Mississippi Center for Investigative Reporting. Thanks so much for joining us tonight, MCIR Live. And because of your support, we're able to do important investigative stories, such as the ones we've done for this, stories, and we continue to write them about diabetes, the rising storm, which are on our website, which is MississippiCIR.org. So your support has helped make today's event and other events like this and our stories possible, and we appreciate that. So, but today is a great day to talk about diabetes in America and what needs to be done. And we couldn't have three better panelists to talk with us. First, we have Dr. Foluso, is that Foluso, if I got that right? Fakorede, who's the CEO of Cardiovascular Solutions and a cardiologist. And he's really dedicated to help improving the circulation of those battling diabetes in the Mississippi Delta, so that they don't lose limbs and can live healthier lives. And next we have Nurse Practitioner Retha Dudley, who's trying to make a difference in the most diabetic place in America right now.
Wow. Yeah, lucky us.
Yeah. And finally, we have Dan Hurley, who's the author of Diabetes Rising, which, if you haven't seen it, was made into a PBS documentary as well, which is a very good documentary. And so here we are, 100 years after the discovery of insulin, isn't it? You know, it's kind of, it seems appropriate, doesn't it? 100 years after the discovery of insulin, you know, they won the Nobel Prize for and kind of famously sold the patent for $1, saying it belonged to the world. And now, and now, Dan, how was diabetes treated a century ago? I know you talked in your book a little bit about this. You know, how was diabetes treated back then, and how do we get to today where insulin might cost more per month than a big screen TV, you know?
So it was, you know, diabetes has been around since ancient times. They thought it was very rare back in the day, and only toward the end of the 19th century did people start saying, gee, this thing is growing fast. And it grew like tenfold in a matter of 20 years, from 1880, well, 40 years to 1920. And both type 1 and type 2. So they were both growing. And at first, nobody had a good handle on what to do. So doctors would have all different ideas. And one doctor came up with something that actually worked, which was eliminate all carbohydrate and just eat protein and vegetables. And that kept a bunch of people alive who had type 1 diabetes, little kids. And when insulin was finally available in 20, wasn't it 22 or 23?
When it was available, yes.
And that they finally, you know, there were kids that were skin and bones, and they pretty well thought it was a cure, and that's how it was presented. You know, here we have this terrible disease, we give them insulin, and they are cured. And you know, that's where they ended. You know, Hollywood would end the movie right there, right. But unfortunately, it kept on going. So,
yeah, and it has.
Mm-hmm.
So, Retha, I know you and your husband offered a free healthcare clinic in Newport, Arkansas. What did you often see when the patients came in? They hadn't, obviously, a lot of these folks hadn't gotten any kind of healthcare at all. What? You know?
Yeah, we ran a Christian clinic for probably about 3-4 years until the Affordable Care Act came into effect. But we were seeing people coming in that had diabetes for years and didn't even know it. I mean, it was obvious. You know, they'd come in with renal insufficiency already, and sores that wouldn't heal, and they just didn't have the money to go to see a provider. And so we were seeing some of the sickest people in Jackson County at this Christian clinic. It was a free clinic, and we saw a bunch of diabetes and hyperlipidemia. We saw hypertension, a bunch of it. But like we were talking earlier before the video started, was that all of that just kind of goes together. If you diabetes, heart disease, strokes, peripheral vascular disease.
Right.
But we were seeing a little bit of all of this.
Yeah, and speaking of that, Dr. Fakorede, I mean, this is kind of your area. You know, you're kind of ground zero for the for this war.
First of all, thank you for hosting this and for having me. Glad to be among my esteemed panelists. I'm an interventional cardiologist and also what we call endovascular specialist or limb salvage specialist. And what that means is that diabetes is, it's one of the unique challenges to our healthcare system. I think the two that pose the greatest challenges right now are diabetes and obesity. And I call that the diabetes epidemic. And they're both related. And if not caught on time, they lead to microvascular challenges, as been mentioned, retinopathy, nephropathy, and neuropathy. And then the macrovascular challenges that you see, which are basically heart attack, strokes, kidney failure, and peripheral arterial disease, which is basically the narrowing of the blood vessel in your lower extremities that, if not caught on time, treated on time, can lead to non-healing wound ulcers and ultimately an amputation first strategy being offered to patients. And the process in terms of the clinical, economical, and human impact of this disease is something that is very disheartening to hear. Peripheral arterial disease affects 20 million individuals, and the awareness of it is less than ALS, which affects less than 100,000 people. You have a country where we spend trillions of dollars in healthcare, and this amputation epidemic is actually a multi-billion-dollar problem, predominantly paid for by Medicare and Medicaid, because those are the recipients, in addition to uninsured, they're getting amputated. And we figured out that if we can have preventative strategies to identify these patients early on, or diabetics or pre-diabetics, lifestyle interventions and modifications, address their blood pressure, their weights, if they use nicotine use, stop. That prevents the progression. We cannot control age, right? That's a non-modifiable risk factor that we all have, and genetics, we can't control that. But if our lifestyle and all those interventions are important. But what's sad is that for us to do that effectively, the social determinants of health have to be in play. Some of these patients, it's one that is not equitable for all. And so you see the disparities in treatments, in screening, and outcomes when it comes to not only the progression of this disease to where they get to an emergency room and these diabetics are being offered an amputation, in spite of the fact that 90% of those amputations are preventable with interventions that are limb preserving and life-saving. Of note, 80% of all amputees who have a major amputation will be dead within 5 years of an amputation.
Wow.
Right? So that is the tragedy in all of this, is that they die from major adverse cardiovascular events, which are heart attacks and strokes and death. And that is what you see in this patient population. Probably 130,000 out of the 200,000 amputations a year are done on diabetics.
Wow. And is there some belief or study that this is somehow speeding it, like by having an amputation rather than, say, doing what you're doing, which is
great question. No, the evils of amputation are, one, it's more costly, it's deadly, as I've told you. It's costly to the patient, but also the family. These amputation rates are higher in what we call the amputation lottery of America, in socioeconomically lower communities of color, patients who live in rural areas. where transportation and again, where the understanding of the health literacy of these patients are not as high as others. Economically, affordability of the medications, as we've talked about, is an issue. And just understanding what a physician tells you, or what a nurse practitioner or a nurse tells you in a hospital visit, and the time spent to understand what is at stake, rather than just saying yes sir, yes ma'am to whatever a physician tells you to do. It's why, how did I have pre-diabetes or diabetes? What are my numbers? How do I prevent this neuropathy, or this lack of sensation in my toe, to prevent from getting to a non-healing wound and ulcer? Who are the doctors that I can go to do minimally invasive procedures to address a blocked artery before I need an amputation? What is a second opinion? What are the risk factors that I have to manage, like my blood pressure? What are the goals of those interventions? What's my goal of my hemoglobin A1C or my sugar level? These are the things that patients just don't know. And once they don't know, they become a product of the system that's designed to get the results it gets, which is our healthcare system.
Mm-hmm. Well, Dan, we kind of, it seems like from a global and of course national basis of diabetes, we're losing the war, so to speak. You know what I mean? I mean, it's not like we're progressing or doing better. It seems like we keep doing worse. So how can we win, or what is it we need to do, Dan?
Well, right now the system is based, so the drug company makes money when a drug is prescribed, and they've got more and more and more medicines. You would think, with all the type 2 medicines and all the breakthroughs, that diabetes would be, a thing of the past. Instead, it's the one disease that keeps growing as heart attacks go down, and cancer deaths go down, and all these other deaths are going down, but diabetes keeps going up. So what seems to be needed is to, instead of rewarding every procedure, every drug, every time you do something, here's the money. What seems to be needed is a system where they give a hospital or a healthcare system responsibility for a region, and they go, here's how much money you get, spend it wisely. And so now they want to spend, that healthcare system wants to avoid having to do surgeries, wants to avoid having people get sicker and sicker. They want to prevent all that. So now they get to save the money, and the doctors and the hospitals can have more to, whatever. That, and there is hope that kind of system will come. There were small models designed from Obamacare, and the hope is that will be implemented, and it's probably inevitable, because the system just can't keep going the way it is. It's healthcare costs going up, and outcomes like diabetes getting worse and worse. It's kind of crazy.
And Jerry, can I just add to what Dan
Please go right ahead.
mentioned? I think his point is well taken, in terms of our focus on our healthcare system should focus more on prevention, exactly, rather than intervention. And I say this as someone who went to school for 18 and a half years to become an interventional cardiologist. The irony in saying that, right? My job is to go in and intervene and do procedures. But I totally, after spending 7 years in Mississippi, the way to prevent patients from ending up in the river where we're picking out their bodies is to figure out what's going on before they jump into the river. And so that preventative strategy upstream is something that our policies have to be concordant with. The problem is that we do not have like for instance, the U.S. Preventive Service Task Force I know has decreased the age requirement on screening for diabetes, but what are the other things they need to do? We need to start preventing and being rewarding physicians for screening these patients for other complications and incentivizing that early on in the process, not waiting to do procedures on these patients later on and paying that drastic cost. It's a mindset that has to change, and people that inform such policies, unfortunately, are not ones that are in the trenches.
Yeah, and Retha, you have been in the trenches, you and your husband, and you. One of the things that impressed me is y'all were very aggressive in treating pre-diabetes, which a lot of people don't think about. They just think, well, I don't have diabetes, or doctors even say that. Oh, you're okay, you don't have diabetes. Why was that? Why were you so aggressive?
Well, several reasons, but let me say something about the task force and about them changing their recommendation on screening. It was 40 years old, and it's now 35 years old. They're saying start screening all non-pregnant adult that's obese or overweight at 35 to 70 years old. But they also added another recommendation that I was so glad to read, and that's to add metformin as an intervention. Now, metformin is not FDA approved for pre-diabetes, but it's approved for type 2. So I was glad to read that, and maybe this will get more providers on board to start metformin. And metformin is a great drug. It's a safe drug. And I think the doctor would agree with me on this. And it might prevent or delay the progression up to full-blown diabetes. We could keep them at a pre-diabetic state. The reason why we were aggressive is my husband, he's an internist, and his parent, mother and father, both diabetes, type 2. And when metformin came out 25 years ago, I think it was glucophage, 25 years ago, metformin came out. He was checking his blood sugars, and he got a 3-digit number. I think it was 101, 102. Well, and he was overweight. He carried his weight around his trunk, and he knew that he was going to have diabetes. That was the future, and he knew it. So he started himself on glucophage to prevent. And he's 85 years old now, and he's never became type 2 diabetic. He has stayed in the pre-diabetic state.
That's fascinating.
And that's the reason why we were aggressive. We saw firsthand what it could do. We could delay. Yes, we could delay.
And so someone comes into you, they're they have those numbers or whatever.
Yes.
Mm-hmm.
A 3-digit number.
3-digit number. What are you going to tell them? What do you say to the patient that comes in? Well,
if I get a 3-digit number, anywhere from 100 to 126, I'm going to go ahead and get a hemoglobin A1C, because I want to see what's going on. If they're 5.7 to 6.4, then I'll tell the patient, you are pre-diabetes. You have it. And of course, like we said earlier, we don't say you're diabetic, they don't want to hear that word, that I am a diabetic. They don't want, because they think about shots. And so when I'll tell them, this is where you're at. We need to do some lifestyle changes. We can prevent this. I review the diet. I'll review the exercise with them. And I'll give them 3 months. And during that 3 months, I have them to come in and get weights. I want to know what they're doing in the 3 months. And then if they come back in 3 months and they're still in a 3-digit number and their hemoglobin A1C is still in pre-diabetic state, then I will initiate metformin at that time. And all I have to tell them is, I have a drug that's going to make you lose some weight, and it's not going to get your blood sugar too low. But I am aggressive, though, with lifestyle changes. I'll review diets, exercise. I'll try to motivate the patient, get them excited about wanting to do some health, make some healthy choices in their life.
Right.
Mhm.
Right. And Dr. Fakorede, I know that Black patients, as you kind of talked about what you're dealing with, are losing limbs at what, 3 times the rate of other patients?
Correct. Black patients are losing losing their limbs at amputation rates at 3 times the rate of their white counterparts. And if you look at every risk factor for peripheral arterial disease, we look at age over a certain age, so age over 50. But if you have diabetes plus a risk factor or independent, so hypertension, high blood pressure, high cholesterol, nicotine use, chronic kidney disease, patients who've had coronary artery disease or stroke, or family history of peripheral arterial disease. When you look at all those risk factors and you break it down even by racial demographics, you see that African Americans predominantly carry a higher risk of those risk factors. And so it's not shocking to hear that their symptoms have progressed to a point where they weren't screened for it by the time they were diagnosed. Not to mention there's this embedded mistrust with the healthcare system, and some of them just do not seek out care or are not treated with quality care. So you can have access to care, but the question is, you get access to quality care. And so the combination of that plus the social determinants are in play when you talk about how they end up under the knife of a surgeon. But you have to also recognize that, what Retha mentioned about prediabetes, 80 million people have prediabetes, right? 30 million people have diabetes. If we were to focus on the pre-diabetic population and to say, well, who are the patients that need to get screened? What are some of their challenges in getting identified or in intervening upon these patients? How can we as a community meet them at the level where they are to intervene upon them? And then let's follow them and see what these outcomes are. Maybe we won't have that such disparity. And 2, what are some of the gaps in terms of the multidisciplinary teams that are available? For instance, Mississippi. Mississippi is the only state where every county is represented in the diabetes belt, right? But we only have, 7 endocrinologists or 8? I mean, it is unacceptable. I trained at New York Presbyterian Hospital in Cornell, New York, and Upper East Side. I can find an endocrinologist in every 3 to 4 blocks that I go to. So that is a specialty desert. And so these primary care doctors and nurse practitioners like Retha are inundated with seeing over 100 patients in a day. And by the time they get to, their blood pressure, their meds, reviewing their meds and making sure that other issues are okay, they don't have time sometimes to take off their socks, to check their pulses. And then it just leads to a non-healing wound ulcer. And ultimately, by the time I identify them, it's late stage, kind of analogy of late stage cancer, identifying late stage cancer, and their prognosis is bad at that time.
And Dan, we were talking about this before, the diabetes belt in terms of its connection to poverty. Talk about that, what you kind of discovered in your journey in writing a book and writing about diabetes.
Yeah, I mean, it doesn't take a genius or a sociologist to notice that if you go to, the Upper East Side of Manhattan where wealthy people live, boy, everybody looks fit and thin and, great. And if you go to West Virginia, Mississippi, Arkansas, you walk into Walmart, holy cow, people have a lot more weight on them. And what that really is about, it's we often want to, family members and even diabetics themselves blame themselves for their behavior. And it's reasonable. I mean, obviously, if people ate less, if they exercised more, yeah, they'd be doing better. But it's not like all the people in West Virginia woke up and said, hey, let's get overweight. They didn't do that. And it's really that you're living in a place where you look around and, you know, everybody else is living like this, and this is the way it is here. And that is where, you know, the only way this is going to change is to come at it from a big picture point of view of, you know, changing our social expectations, changing the way things are organized. You know, what kind of food is available, what kind of doctors are available in those areas, how are kids educated, what are the opportunities for exercise. All of that makes a huge difference.
And you know something quite a bit personally about diabetes as well. I guess we should
Yeah,
add this
you know,
part. Go ahead.
so when I went to college, my first Thanksgiving in 1975, I went to see my brother in Iowa. I hitchhiked there because that's what people did in the 70s still.
Right.
And I started feeling sick, and I couldn't eat my Thanksgiving dinner. In fact, I ate one crumb, literally ate one piece of stuffing, and then felt nauseated. And I took a bus home. I was so thirsty that I said to the bus driver when he stopped to drop off some people, I said, I've got to go out and get a soda. He said, nobody's allowed to get off. Only new people getting on. I said, I've got to go. And what did I get? A Coke. and I ended up diagnosed with type 1 diabetes at the age of 18. I've had it ever since. I'm 64 now. I'm coming up on my 50th anniversary. And what's most amazing to me is that when I developed it, nobody I knew had it. Nobody. I didn't know anybody at my college. I didn't know any friends. I didn't know any family. I didn't know anybody. And it was this really weird, rare disease, like getting some weird cancer or something. And today, these days, every elementary school has in America pretty much has at least one kid with type 1 diabetes. In my own town, my closest friend has type 1 diabetes. The pastor at my church has diabetes. The woman down the block has diabetes. The girl around the corner, the teenage girl, she developed it 10 years ago. And it's become so much more common, and it's really strange. If you just think it's type 2 because we're all eating too much, but then why is type 1 growing so fast as well? And that's a big fascinating mystery.
Yeah. And I think you and I've talked about this before, but we often think, the type 2, like you're saying, is just caused by diet, outside factors, has nothing to do with hereditary. And then type 1 is strictly, you get it hereditary. There's nothing you can, but yet they seem to be connected. You know what I mean? It's very fascinating.
They definitely are connected. Actually being slightly overweight makes you more likely to develop type 1. And many of the other factors that seem to be at play with type 2 include exposure, vitamin D levels from getting outside. People, hey, what are kids doing these days? They're sitting inside looking at their phones instead of being outside. Everybody used to be running around out and about. And also there's concerns about pesticides and exposures to these chemicals that are ubiquitous in the environment that could be having an effect. The fact that we are all exposed to fewer microbes, bacteria, that our environment is so much cleaner these days. It's thought that perhaps when people lived on farms and were exposed to all sorts of funky bacteria and soil, that maybe that had some effect. They're really grappling with what is at the root of all this.
Interesting. Well, Retha, I know you and I've talked about this before, but talk about what kind of diet. Let's say someone comes in and you discovered their A1C levels are such that.
Okay, sure. What I do to start off, like I said, I'll talk to them about lifestyle changes,
Right.
and I'll start reviewing how they eat, what are they eating, and then I'll tell them after I go through their diet, I'll tell them if it's white, I want you to spit it out. Anything white, just spit it out. It's not good. It's carbohydrates. I want them to go on the low carb diet. And I'm not going to ask patients to learn how to start carb counting because they're not going to do it. In my experience, patients are not going to write their calories down. They're not going to write down carbs. So I try to make it simple. Just stay away from the carbs, do low carbs diet, eat fresh veggies, fresh fruit, make healthy choices, stay away from candies and cakes, bread, potatoes. Potatoes is one of your good carbohydrates actually, but after we put everything on our potatoes, it's not any good. So I tell them, leave potatoes off. And then noodles, rice, spaghetti. I mean, I'll just go through the list with them, and then I'll move on to exercise. I'll tell them let's start exercising, and I'm not going to ask them to get out there and start walking 30 minutes all at one time, because most of these people are 50 pounds, if not more, overweight. And so I'm going to say, let's do 10 minutes 3 times a day, or 15 minutes twice a day, until you can build yourself up to start walking 45 minutes a day. And if I put it like that to the patients, to start slow and work yourself up, I get more out of these patients. I get more motivated to try to do healthy things or make healthy choices. And then I review the drinking is the other thing. Whenever it amazes me when you tell them to cut sugars out, they don't count Cokes.
Exactly. That's what I was going to say.
Or in these southern states, unsweet tea.
There's no such thing. Is there unsweet tea?
I mean, what? Give my sweet tea up. But if you can get them away from just bad choices like fruit juices, they're just loaded with sugar. It's just simple things that they just don't really know.
Exactly.
If you'll just tell them. And then I always try to get them to a dietitian. A registered dietitian is a great help. They'll have time to sit down and review stuff, their diet with them.
Review their diet and things like
Mm-hmm.
that.
Yes. Mm-hmm.
And what are the goals? Weight goals. What are your weight goals generally? What are your weight goals for them generally? What, 10%?
I tell them, no, 10%. That's what I tell them is 10%. The ADA says if someone would lose 7% of their weight and do moderate activity, physical activity, that lowers their risk. But I tell them 10%. If you weigh 200, let's work at 10% of getting this weight off. And in 3 months, if we're not getting anywhere, I'll check everything in 3 months. And like I said, then I'll start metformin, and that'll help them with the weight, because that's one of the good side effects of metformin is they'll lose a few pounds.
Well, that's good. Dr. Fakorede, talk a little bit, and we've kind of talked about it a little bit already, but kind of the health inequities we're witnessing through this. Places like the Delta.
Yeah, it's the American Heart Association just had in the publication in their journal looking at basically the projection of diabetes, both type 1 and type 2, over the next couple of decades. And the sad statistics are that we're going to see high prevalence of diabetes in our younger population, especially kids who live in places like the Mississippi Delta and in communities of color. And that is what is so sad about this, is because, you're going to have a lot of young people now having heart attacks, strokes, and having limbs lost if they're not identified early. We've looked at disparities in treatments and in outcomes and the burden of health of America. The Journal of American Medical Association, JAMA, published an article in March of last year looking at the burden of health from over a 20-year period, dating up until, I think it was up to 2020. And what they looked at was that the two unique health challenges that are posed to our healthcare system right now are both poor glycemic control, which is prediabetes and diabetes, and abnormal BMI, which is obesity, right? And when you look at the number one outcome in that, it's cardiovascular disease. And when I say cardiovascular disease, under that framework is your heart attack, stroke, and peripheral arterial disease, all under there. Heart failure is something that we haven't done a good job in controlling our overweight population in terms of getting them into what our desired goals are. We haven't gotten a hand on diabetes. We haven't gotten a hand on high blood pressure. We haven't gotten a hand on heart failure, heart attack. Heart attack rates declined by in some communities, but in communities of color, those rates actually have gone up. Amputation rates also have gone up in certain regions. Actually, comparing metropolitan to rural areas, fascinating study just published a month ago where they looked at big cities, Atlanta, LA, New York, Philadelphia, Chicago. Amputation rates were very high in regions of either low socioeconomic status, predominantly minorities, right, but they had big hospital systems around them. So they had vascular specialists who work in these areas. So what explains that disparities? And that's where this conversation gets into, okay, why are we still having disparities in treatments and outcomes, even when sometimes you control for either access or social, determinants? And so is race a factor? Is there preconceived notions that are in place in the treatment continuum where some are treated differently than others? Are there unconscious biases in place? And what can we do as a healthcare system to address that? Because we're still not seeing those patients represented in the positive outcomes when you look at morbidity and mortality versus early interventions. And diabetes is the perfect example where we're not seeing that outcome that's positive, all negative.
Yeah. Wow.
Look at the number one cause of dialysis. So patients, I forgot to mention, look at the dialysis epidemic as well.
Exactly.
Diabetes being your number one. It's just a microcosm of everything that we've said. We don't catch it early. As if everyone was as aggressive as Retha and her husband, these patients will not develop those complications of blindness, dialysis, amputations, attacks.
Yeah. All those symptoms that we, people don't think about necessarily unless they're familiar with diabetes, that they can be affected. Like I said, blindness. It's one thing with diabetes is one of the top causes of blindness, and dialysis. Which talk about, even if you're viewing it strictly from an economic standpoint, dialysis is about the most expensive thing you can.
Exactly, and if you look at dialysis, most of these patients, unfortunately, are the chronic management of a dialysis patient. They are ones where they are excluded in a lot of the clinical trials with all the drugs that are coming out. Right, we always exclude our patients who have chronic disease who are on dialysis, and unfortunately, a lot of these patients are, the patients that we're trying to advocate for to get some representation, and so they're excluded, and therefore it's they're left to basically not have a fighter's chance, and that's all. And that's what they deserve. They deserve a fighter's chance, and the same is applicable in all other specialties, specialists that are specialty care that are involved in this fight.
I'll let our audience know, I should have mentioned earlier, if you have a question, put it into the Q&A, and I'm sure they'll love to answer your questions. or maybe not, maybe they won't, but anyway, you can ask. So we're talking about the cost of diabetes, and the estimates I've seen, something like $327 billion a year, that diabetes costs us, either in most of it direct medical costs, and then part of it lost wages, time, and those kinds of things. I mean, and the numbers would suggest, what is it, by 2026, I think Medicare is going to begin hitting a wall, in terms of running a deficit unless something changes. And $1 out of $3, I think, is for diabetes care. So what's it going to take, Dan, for us to take diabetes seriously as a nation? I mean, what's got to happen,
Go ahead.
Yeah.
I was just going to comment what I find amazing is in 1958, 14% of America was overweight. Today, we have almost 50% of us overweight.
Exactly.
And if we don't get aggressive there, then pre-diabetes is right, is right with that. We've got to be aggressive with the weight. And, I encourage patients that's really overweight to go. I send them for consultation for a gastric bypass. I mean, I'd much rather see someone go in and get a gastric bypass. That's going to put years on their life. But I just feel we need to get aggressive there. We're not going to get ahead of the game.
Right. What about you, Dan? What are your thoughts on that?
Oh boy. How to move the behavior of, the entire population. What's funny is that back in the day, in the 20s and before then, it was only wealthy people who were overweight.
Right, exactly.
For the most part. So when you think of these big rich guy, he would go out to eat and eat these enormous feasts. Meanwhile, the average person is barely getting by, and they're eating mom's cooking, and mom's cooking generally is not the problem. It is McDonald's and all of the restaurants and all of the easy access to going into the grocery store and buying even something as seemingly healthy as cornflakes. You get a big box of cornflakes. Oh my God, that is so much carbohydrate.
Yes, right.
So, if back in the day it was the rich who were overweight and others who were thinner, that just shows you how the social expectations and the environment that you're in have a huge, that is what's causing this. And so what is it going to take? They had a war on cancer, which didn't go very far back in the 60s or 70s. They're still fighting it. If there were a war on diabetes and overweight, and again, if these hospital systems made money not for giving out pills and doing amputations and heart surgery, but for protecting people's health, golly, that suddenly they would have a big interest in taking care of us.
Yeah. And Retha, talk about, I know you didn't realize that Newport was the most diabetic place, but now that you've discovered that, you and others have kind of gotten to work, so which fascinates me. I'd love to hear.
What after you had our little visit, it's like, thank you, Jerry, for coming and giving me this good information here. But we, Guilford and I kind of brainstormed, and so I got some people gathered up. I have 2 nurse practitioners, adult nurse practitioners. I have 2 RNs. I have 2 teachers that has experience writing grants. And then I got the hospital involved. I've got the marketing person involved with us, and then my pastor, who has some experience on starting community gardens. And
Right.
so and then she got our county extension office involved. So we've all kind of gathered together, and what we have decided to do is we're going to start going out and do screenings. We're going to do pre-diabetic screenings. The hospital is going to help us. I believe they're going to just do our hemoglobin A1Cs for us. We've got questionnaires that we've downloaded from the CDC. And we're going to start, we have 3 food banks in town. So we're going to start with the 3 food banks. One of the food banks took a poll of the cars that came through to get food. They had 60 cars, and 40 of them had been screened or had diabetes. 20 of them didn't know if they had diabetes and never been screened.
Hey, Retha,
So,
what if they required everybody to park their car at a parking lot, like, a quarter mile away, and have to walk over? That would burn a lot of calories.
That would be good, wouldn't it? I might suggest that. We might not get any screeners though.
Nope.
But I'm excited because I see that maybe if we start screening, and I think I read the other day that there's 88 million people that's walking around with pre-diabetes, and only 10% of them knows that they have it. So if we can, identify these patients, what we'll do is we'll refer these patients then to the hospital, to a personnel who will refer the patient to a provider to do, for treatment and follow up. We just want to identify them is what we want to do and get them referred.
We got a question from Joseph Silver. He says, if a diabetic is able to maintain a healthy blood sugar range through various treatment regimens, drugs, diet, exercise, etc., are there any studies that show a decrease in cardiovascular or peripheral disease in the long term versus someone who cannot maintain blood sugar as well? You want to take a shot at that, doctor? Or?
Yeah. I mean, that's that's a great question. So what we've seen in the cardiovascular space, and peripheral arterial disease is one of the cardiovascular diseases. So I'm going to use that term for the purpose of this discussion, cardiovascular disease, is that when you look at patients who are diabetics, we found that those diabetics come in with are more likely to have accelerated disease, multi-level, meaning that the level of blockages they have in their heart and their legs are basically higher than non-diabetics. These patients come in with extreme late stage of the disease. Their amputation risks are higher. They die at a younger age. They have the longer the duration of their diabetes, the more likely they have the microvascular complications, the neuropathy, which also increases their amputation risk. And so and actually their glycemic control at the time of intervention actually matters. Sugars matter in terms of how well the wound heals as well, right? Mm-hmm. So the culmination of all this, I mean, I think it's been justified, and that's why their recommendations when we treat these patients to get their A1C less than 7% is what our guidelines say as American College of Cardiology, American Heart Association. But we've seen that these patients actually have better outcomes when we identify them early on, intervene early on. Just of note, just to let people know this and your audience know this, if you look at all the cardiovascular trials to date, meaning all trials done in the cardiovascular space, only 5% have included African Americans.
Wow.
5%. So the reason why I say that is because the question asked though,
So 5%, only
5%,
5%.
only 5%.
Oh, wow. They're way below the
Right, way below,
population.
right? We're 13%, right? And Hispanics, women are underrepresented in cardiovascular trials as well.
Really? That's
33%,
fascinating too.
33%.
Mhm.
So if you look at their outcomes as well, you're seeing that now there's actually a disparity. That in itself is a disparity. And so what the take home is that the question asked, well, what are the trials saying? Well, the trials are underrepresented in terms of what they're saying because the patient population that is mostly affected are not even represented
They're
in
not even represented in studies.
the right. That is the disparity. So the onus, pushing back the onus is on the people who are not only designing their trials, but the recruitment and retention of these patients in the trials, and all the factors that go into it. And social determinants too plays a role, and the trusting the outcome and the system, all that plays a role in terms of determining those comparative values.
You know, when I developed type 1 back in the 70s, so, you know, it wasn't considered a death sentence, but, you know, the general vibe was, watch out, man, you know, the train wreck is coming down, you know, down the tracks.
Mm.
And it was pretty scary, quite scary. And you couldn't test your blood sugar at home. There was no, you know, the little finger prick thing didn't
Mhm.
exist. That happened in the beginning of the 80s. Insulin pumps. I have an insulin pump right here. You know, yeah, this is my little insulin pump. I have a thing that shows, this is showing my my blood glucose level right there. It's a continuous monitor. So I have now gone 47 something years, and I don't have any complications. Nothing with my eyes, nothing with my kidneys. You know, I'm a slightly overweight. I'm a little overweight, but I go running, and yeah, I think taking care of yourself is absolutely going to prevent
Mhm.
all the downsides.
Mhm. Certainly help, I would think, in terms of if you're exercising. Of course, that helps your heart, helps your circulation.
Yes.
I'm sure, doctor, I'm sure you would.
It decreases your chance of dying by, you know, significant. I mean, we're talking about 90% if you do all those things. I mean, it's, you know,
Really?
lifestyle, aggressive lifestyle interventions, just in non-diabetic, all comers. I mean,
All comers, yeah, everybody.
they're all about, you know, decreasing your blood pressure points by 10. I mean, they're just different little things you can do, that we as providers try and sit down and have that discussion with the patients. What we see is that most of these patients are missing that encounters, and that's why, you know, programs like Retha's and books like Dan's are important for our patients to be able to relate. They're relatable.
So what's on the horizon, or is there anything on the horizon in terms of treatment? This is for everybody that you know of that's kind of out there that may be up and coming. And I know, Dan, you mentioned the continuous glucose monitor and stuff like that, you know, whether it's digital or drugs or whatever it is, anything on, or, you know, promising studies or what, you know, is there anything out there that any of y'all would point to that maybe could offer us a little bit of hope?
You know, there's all sorts of studies trying to prevent
Exactly.
diabetes, and you know, it's a hard game. I know that at there's all sorts of efforts, and I wish I could say something looks super promising. There's possibilities. You know, I get updates from medical centers, researchers all the time, and you know, if it was already available, you you would hear about it. It's preventing a disease is really complicated thing. And, you know, I honestly, the biggest thing that could help us is if the federal government changes how doctors and hospitals and medical centers are reimbursed for care, and to focus on prevention.
Focus more on prevention.
That would make a huge difference overnight, and probably more than, you know, any of these drugs that you see on, you know, if you're watching TV and there's another drug for diabetes, you know, you would think those, that would be the answer. It doesn't seem to be.
Well, I've always heard, I don't know if it's true, but I've always heard that if running were a drug, everybody would want to take it. Because
the number one preventable cause of death in the country is your lifestyle and dietary modification.
Exactly.
And so that is an early prevention strategy. But I think for me, it's, you know, as much as there are a lot of companies and universities who are trying to find either preventative, you know, drugs out there, I think, you know, in the PAD space, it's policy to focus on prevention and to address some of the gaps in policies that could aid in that. And the one example is the Amputation Reduction and Compassion Act that we've been involved in, where we're trying to get HHS and Congress to apply dollars that go into prevention, so we can identify and screen my patients, Retha's patients, early on in the process at no cost sharing to them, and saying, hey, this is free, get screened. And then awareness levels, awareness campaigns that are funded by those government dollars to not only identify what diabetes is, but peripheral arterial disease, raise awareness on both conditions, and treat them early on with interventions that we know are sustainable long term, before they need medication or interventions like procedures. That's how we have a clinical, economical, and human impact. And ultimately, that's how we decrease the cost burden to our healthcare system.
Exactly. Retha, any final thoughts before we wrap up?
No, I agree with Bob and the doctor. I mean, I wish that was something easy, but it's not. It's not easy. This is not going to go away.
Yeah. Prevention's the key, obviously, and lifestyle.
Prevention is, yes.
And through lifestyle, through eating right. Like you mentioned, we don't need to stoke up so much on carbs.
Right.
When I was diagnosed in 1975, I can remember you know, I was in the emergency room and the doctor had just told me, you have diabetes. And I didn't even know what that was. And he said, but don't worry, they just cured it in mice. It's gonna be cured in humans, so don't worry about it. And you know, they've cured it in mice about 1,000 times, I think.
Yeah, exactly. I keep trying to cure mice.
Yeah. Thank God we have mice without diabetes.
Yeah, exactly. Well, we're out of time, but thank you everybody for joining us on MCIR Live. We especially want to thank Dr. Fakorede, Retha Dudley, Dan Hurley for joining us and sharing their wisdom on this, and just, you know, reminder, you know, in my opinion here, but I just feel like investigative reporting is kind of the lifeblood of democracy. It plays a very important role, and we thank everyone for your continued support to MCIR, and just really appreciate it, and we have thank yous coming in from the audience as well. So so anyway, thank you so much for joining us, and we will see you next time. Thank you so much.
Thank you for having us.
Thank you, Jared.
All right, bye-bye.
Thank you. Bye-bye.